as I said in the beginning, most important thing is to know your definition very well, okay? And to have some sort of structured thinking in your head. So when you've been asked about the intracranial pressure, as our first slide saying, so what's the normal value of intracranial pressure? The normal value is 10 millimeter mercury, okay? Intracranial hypertension, what do I mean by intracranial hypertension? So this means intracranial pressure more than 15 millimeter mercury. When the pressure goes more and more higher, when the pressure is double the normal, which is 20, you will start to having some focal ischemia, which is some part of your brain will start to be affected. When the pressure is increased again to more than 4 times the normal, which is more than 40 millimeter mercury, you will start to have a global ischemia. What's global means? Means nearly all your cerebral cortex will be affected, okay? So there's not going to be much blood supply to the brain, okay? Right, so causes of high ICP. So as I was just saying, but no one can see the screen. So the skull is a bony structure, okay, which basically cannot expand, right? It's a fixed area. Inside this area, there is brain and there is blood and there is CSF. Okay, so any increase in the ICP will be increase in the volume of any of these structures: brain, blood, CSF. Brain can happen in, well, very easily, can expect that, tumors, brain edema due to ischemia, due to infection, due to any metabolic reason as well. Okay, like when you see cerebral edemas, for example, in people who got hypoglycemia. And so or hypoxia, okay, which is unfortunately sometimes can happen in an ICU, especially nowadays. Blood, so when you see any increase in the blood volume, like subdural hematomas, extradural hematomas, intracerebral bleed, and subac hemorrhage as well. And last is CSF, which is, I mean, you see it not quite often. You see it like hydrocephalus, which is again can increase the intracranial pressure. Okay, second question will be, what are the symptoms of the ICP? You will be impressed, okay, when this question is being asked in any Viva. What is the clinical picture? What is the symptoms of high ICP? Okay, people start saying very tricky stuff in the beginning, okay, which is, I think, is not the best idea. They'll start to saying, okay, high intracranial pressure. Okay, so the first symptom will be seizures and fitting, okay, and people will get projectile vomiting. No, what you should start with basics. High ICP, first symptom is headaches, okay. All those people, when you talk to them, the first symptom they got is headache, okay. So headache is the first thing to say. And then second thing, some of them will got projectile vomiting, okay, and then when the headaches starts to be more and more severe, sometimes it goes completely and then come back, okay, and then they'll start to feel themselves all right, slightly drowsy or confused, okay, and then they'll start to have some seizures, okay, which is fits, and then unfortunately, if they didn't call the ambulance quite early and they try to do something about it, they can get to coma and completely lose their consciousness. Okay, these are the symptoms, okay, which the patient will tell you about. Signs, what are the signs? The things which you can see on your patient. So when I'm sure all of you have seen people with high ICP coming to you in the ED recess, and he came down and assessed them. So dropping of the GCS or fluctuating of the GSS. What I mean by fluctuating, GCS sometimes drops to like 8 or 9 and then come back again to 12 and then drops back to 8 and 7. These things can happen. So drop or fluctuation of GCS. The second is you can see focal or global ischemia, which is something you can see on the scan actually, but you can see clinically, you can see they get sometimes they get a bit of weakness and numbness in their limbs, and sometimes they cannot move their limbs. And that's why it's a very good practice to document what are the baseline of the patient movement before you intubate them. If you're going to intubate them, you should document that GCS and what limbs they are moving. Okay. Second thing, any patient like that, okay, you will definitely do your ABC A, B, C, D, and you should check their pupils. Okay, so pupils, they might got papilledema. Papilledema is not a good sign. Okay, this is reflecting the high intracranial pressure. And sometimes pupillary changes. What I mean by pupillary changes, unequal pupil, okay, unequal pupils. So you see one pupil dilated and the other is still constricted, okay. And this is again a sign that there is hemorrhage happening in the brain, okay, something acutely happening. Cushing reflex as well, okay, Cushing reflex as well can happen, okay, which is as we all know, severe hypertension, bradycardia. And that's actually a very bad sign. Okay, and this is we're moving us to the other topic, which is coning. Okay, what do I mean by coning? So coning, when as I said, the patient's starting to have Cushing reflex, this is mean the brain stem is nearly, okay, compressed. Okay, and that's why you see hypertension, you see bradycardia, you see respiratory irregularity, because all the cardiovascular and respiratory centers are lying in the medulla, right? So when they are compressed, you will start to see this sign. So coning can be two types. Can be central coning, which is the cerebral tonsils will be compressed. Again, it's the foramen magnum, and the second is tentorial coning, which is the temporal lobe will be compressed, the brain stem on the contralateral side, and will compress the oculomotor nerve on the ipsilateral side. And that's why sometimes you can see unequal people, okay, because it's compressed the oculomotor nerve on only one side, okay. Dropping of the GCS and Cushing reflex as well, and decerebrate rigidity. I'm sure you've seen that before when they are becoming very, very rigid. So, and this will move us to indications of measuring the ICP, okay? How to measure the ICP, we'll talk about this later, but what are the indications for measuring ICP? So if you got a patient with dropping GCS, okay, abnormal CT brain, which means you can see bleeding on the scan, or a normal CT, okay, plus two or more of these. The patient is more than 40 years, the patient is starting to get hypertensive and bilateral or unilateral posturing as well, okay? And that's basically from our NICE guidelines. Okay, measuring ICP. So how we can measure the ICP? Again, as I said before, you try to be structured in the thing. You can say there is non-invasive method and there is more invasive method. Non-invasive method, scan the brain. Okay, so when you do a CT brain, you can see if you can see bleeding, if you can see edema, this is definitely an impression that there will be high ICP. Okay, the intracranial pressure will be high, and you can see sometimes there is no enough room for the brain. We like to call it the brain is quite tight. Okay. And the other way as well is invasive, okay, which we all use in Euro ICU. So you can start with simple things like epidural catheter, okay, and the other way as well, which is quite famous, is intraparenchymal catheter, okay, where you put a catheter, well, sort of catheter in the frontal loop of the patient, okay, and this will be pressure sensitive as well. There will be a transducer pressure sensitive, okay, and it can transduce the pressure happening in the frontal loop of the brain to the monitor, and you can see the pressure. Or you can use more invasive method, which is the ventricular catheter. You can put a catheter in the ventricle, which we mainly use in patients with hydrocephalus to drain the CSF. Why do you drain the CSF? You can measure the pressure as well. Okay, this is the way to measure the ICP. Right, and so what waves you'll be expecting in normal ICP wave? Okay, so if, for example, if you put intraparenchymal catheter in the frontal loop of the brain, okay, and now you can see on the screen what waves you'll be expecting. So you can see there are P1, P2, and P3. So P1 is we call it the percussion wave, which is reflecting the arterial wave of the brain, okay, the arterial pulsing of the brain. And the second wave is called the compliance, the brain compliance. And the third wave is the venous pulsation. That's why it is the least in the amplitude. Okay. Right. Moving now to the abnormal waves. So previously, this is the normal wave which you'll be seeing. Okay. This is if there is nothing wrong happening. Okay. If there is a problem happened, this patient got a bleeding in his brain, you see 3 types of abnormal waves. They call them the Lundberg waves, A, B, and C. A is a life-threatening condition, okay, as you can see on the screen here. So it's a wave with an amplitude of 60 to 80 millimeter mercury, and it can last between 5 up to 20 minutes, okay. And as I said, that's a life-threatening. This means this patient might be dying quite soon. Lundberg B wave of the ICP, as you can see, so it's less amplitude. It's a small short waves, okay, and here the amplitude is just between 10 to 20 millimeter, and it will persist for only between half a minute up to a couple of minutes. Okay. Last wave, which is the C waves, which is just literally a small oscillations. Okay, very small oscillations. You can see it on the right bottom of the screen, and the amplitude is just between 0 to 10 millimeter mercury. Okay. So you can be asked about the Lundberg waves. What are the